Great. So I really enjoyed that last presentation from Simon and the discussion about it. And this does lead on a little bit because I initially thought nothing too much of the topic, Paul, when you first gave it to me. But one of the anaesthetists I work with did send me this and highlighted my talk, and the accompanying text was, "This better end well for me." Actually, there was no smiley face emoji, but I did return with a slightly sweating smiley face emoji. So I'm aware that I've got to sort of get this pitched correctly without making too many enemies. So I'll try my best. Ultimately, the small print of this talk is about team working. And when we think about how a team can work well together, this is a really good example where uh, each individual member of the team has a specific task, and they work together in unity to deliver a outcome, which is the car coming into the pit and leaving in good time with a new set of tires and getting out in front of the opponent car. In reality, in the real world, that just doesn't really happen. And there is a book by a professor of Harvard, I think she is, called Amy Evanson, who describes this concept of teaming and the importance of it, and really how managers need to stop thinking of teams as groups of static individuals who have loads of time to practice doing this team training, as you were saying, and doing that sort of successfully and efficiently, but actually being able to come together as individuals and throw together a team on the hoot, whatever the term is. And we do that all the time in healthcare. And we come together at team brief and introduce ourselves, some of whom we may not know, some of whom are training or are expected to deliver the aspect of their job whilst being trained, and so on, and then deliver the schedule for the day, which for us generally is 2 cardiac surgery operations. Yeah, no intentional resemblance to any Bart's teams, despite the scrubs colours there. But what this comes down to really is, how can we do that? And Sir David Brailsford, who led the cycling, the Great Britain cycling team and the successes, described this marginal gains theory and a method of reaching very high performance levels by consistently or constantly making small incremental improvements. And the power of that is actually quite amazing. And if we just increased, if we became 1% better every day for a whole year, we'd actually be 38 times better, which is a 3,700% improvement. And that can be translated to all sorts of things, such as finance and compound interest, being described as the eighth wonder of the world by Einstein. He who understands it earns it, and he who doesn't pays it, which is absolutely true. And one might think, what is the reality of being a cardiac surgeon when you're a young boy? This is my son in my actual childhood red sort of Ferrari-esque car, dreaming about what a cardiac surgeon might do, and the AI generated image of my Ferrari at Bart's Hospital, which sadly isn't actually the case at all. And although this is AI generated, that is actually how I get to work at the moment on my electric bike. But this is actually the harsh reality of being a cardiac surgeon, and it's in black and white because it is fairly stark. But this is the NACSA hospital report, the National Adult Cardiac Surgery Audit Registry, which is published every year. This is July's publication, and it follows a 3-year data set. And this was put in place for good reason, because of essentially national scandals in the past with cardiac surgery outcomes, and therefore trying to give assurance to the public that cardiac surgeons are doing a good job, and there is no individual that is underperforming or undelivering, not delivering care as they should. So Bart's data here So in the last 3 years, we performed just under 5,700 cases. It translates to just under 1,900 cases per year. And actually, if you look at the raw mortality of 102 patients, it actually is pretty low, 1.79% over 3 years, which translates to 34 elective or urgent deaths in the year and around three, therefore, per month. And actually, if you think about what we're doing, cardiac surgery, which hopefully most of these deaths would be urgent rather than on the elective side, but that's actually an incredible team performance to be able to deliver complex care and do it, so well with relatively few negative outcomes. And this is my individual data. It's by GMC number, but I'm naming and shaming myself. And you can see my listed survival. And this is, I don't know if it's still available for patients, but I think it may now be unit specific. But in the past, patients could actually look me up and see, okay, Mr. Adams, his survival is 98.2%. And of course, that translates over that 3-year period to between 1 and 2 elective or urgent deaths per year, which is the reality. And then look here at the risk profiling. My raw logistic, actually, it may just be, I think it's raw Euro score of 5.33% for that cohort of 278 patients. And if you look at the national average next to it, that suggests I've actually got a lower risk profile than average in the UK. So am I perhaps a little bit risk averse, one could say. And that's despite me having a 50% complex aortic practice. So it just doesn't quite make sense. Either that is correct and I am a little bit risk averse, or there is a flaw in the risk scoring system, which is more probable. And actually then look under here under the Euroscore at the recalibrated Euroscore, which drops it down to 1.5%. So actually, I should be performing these operations and delivering those procedures at only a risk of 1.5% to that population, therefore giving me a target survival of 98.5%. So look, I'm actually, according to this, I'm slightly underperforming, one could say, which seems outrageous to think of as a cardiac surgeon trying to do your best job you can every day. It's broken down into this horrible sort of chart, which if you zoom in, then tells you if your survival is better than predicted and better than the survival probability using their risk model. And then it also flags up if you're an outlier. So that can be that you're actually got a higher survival than expected, which is rare, but that can happen to 2 or 3 standard deviations above. Or what is more concerning for a consultant surgeon is when you alert in the negative aspect, so your survival is worse than expected, either 2 standard deviations where you get an alert or a yellow card, or 3 where it's an alarm and a red card, and you may be forced to stop operating whilst your results are looked into in more detail. Generally, when we calculate a patient's Euro score, we would then sort of halve it to give the patient their, rough estimated risk of undergoing that surgery. If you then extrapolate that by the number of cases I've done in the last 3 years, then you would get I'd get an alert if I had more than 4 deaths per year, potentially, which is quite scary. If you then use that recalibrated score, let me just move this out of the way, that could be as low as 3 deaths per year. So we're really, as consultant surgeons, we're really a little bit on the edge of what we are able to do in terms of delivery. And therefore, and final point here, in addition, that the SCTS, the society that sort of helps produce this report, actually doesn't tell us what the recalibrated risk Euroscore actually is. They use a mystery X factor to help give a recalibrated score. So we're actually flying completely blind on what we are supposed to achieve. And then someone like myself who does 50% aortic, some of which, of course, is the complex aortic arch surgery that we do, You can see here, this is when I looked at in the summer for our sort of 10-year review. I mean, I looked at the mortality of arch surgery at Barts over the last 7 years. And you can see that the gross mortality is way above this, 17.88% over that period. Just over a fifth are redo cases. If we exclude emergency and salvage work, our elective mortality comes out at 7.76% over those 7 years, which is still, fairly reasonable. But over the last 2 or so years, we've been able to get it down to around 4% or just over. So how on earth are we expected to deliver this kind of complexity of cardiac surgery, aortic surgery with just a 1.5% risk? It just doesn't follow. And therefore it goes back to this marginal gains theory. And how can we try and improve outcomes in stepwise manner? One such way is things like stroke. If a patient has a stroke during cardiac surgery, you know that their overall outcome is dramatically affected. So we look to try and improve this at Barts because our stroke rate was way too high, with a gross stroke rate of just under 13% in the past, but our best performance being just over 5%. And that's with the work that we have been able to do with anaesthetists and so on, like yourselves, with experiments and change in protocols. For example, the use of the transcranial Doppler device during complex arch surgery, which requires a very patient anaesthetist to help set it up, and a delay in the start time and so on, and also logistical issues with having to run very long tubing from the central line and so on. But that has translated into a big difference, I think, in improvement in stroke outcomes, particularly in type A dissection, which this graph shows from when we introduced the change in our protocol of antegrade cerebral perfusion in around 2020, late 2022. You can see that our stroke rate in type A dissections has come down dramatically to just over 6%. But of course, there's still work to do. Dialysis rate in this complex arch group can be as high as 25%. And I think the average length of stay in ITU around 12 days. So what can we do to try and help with these high-risk surgeries? We are essentially trying to reduce various factors surgically that we can, such as reducing body arrest times, trying to deploy frozen elephant trunks as rapidly as possible with some fixation, sutures and core knot, and then perhaps a single suture circumferentially around the cuff of the device. How do we manage the subclavian branch, and having in the future, hopefully next year, some rapid deployment devices into the subclavian. So essentially a sutureless supra-aortic anastomosis can help reduce those body arrest times. Inflammatory response is a really big issue. We've had a trial of using cytosorb filters during circ-arrest cases as well as endocarditis cases, and we need to process those results to see if it's had any benefit, and hopefully it has. In addition to things like not cooling the body down quite so much for an arch. We used to go down to 22 degrees. Now we're probably pushing it up to 26 degrees, provided that we can keep the body arrest time minimal and the head arrest time minimal. Of course, we've got to keep the heart well protected, so we have been looking at continuous coronary perfusion over the last year or so. We have used custodial and are looking at Del Nido in the next year, and hopefully some further robotic transcranial Doppler experiments to try and refine what we can do in terms of neuroprotection and particularly neurocognitive protection during these cases. So what I feel is that we can probably save a number of deaths per year by breaking this down into elements. So I think we can save 1 death per year by something being picked up preoperatively, probably with, either at your good registrar, or your anaesthetist can pick up and actually flag something that can be intervened upon before the case. Probably one death per year, something that the consultant surgeon can do to get out of jail intraoperatively, or perhaps asking a colleague consultant surgeon to come in and help. One death per year saved, this is at least, I must add, by some sort of heroic anesthetic management. And I've put here, adding nitric oxide, for example, or something to do that you guys do, which helps us get the patient off bypass and back to the intensive care. And probably having a familiarity with the surgeon does help in that situation. And then there is probably one death per year saved from an ICU rescue, someone who's deteriorating and is recognized and intervened quickly enough and appropriately enough to turn that around and deliver a safe patient to hospital discharge. And all of these things actually prevents me from getting a yellow card or worse, a red card, and having some, time gardening whilst things are looked at. So I'm very appreciative. I think it's worth me saying a little bit about this, and that's a CT scan from one of my urgent aortic cases. And you can see how that must have been challenging from my point of view, but I can also see how challenging that is from your anesthetic and post-operative management point of view. And I can only describe it as it's not just a subspecialty of aortic surgery, but there's so many other things that you need to be able to do to deliver a first-class anesthetic for these patients. And these patients are really sick. They have lots of comorbidities. They may be very young or very old, very large, such as the giant Marfan's patients. Their aneurysm could be pushing on their airways and so on, as well as the procedure demands from my side. And of course, that can evolve very rapidly, particularly if it's a redo and I go into the aorta with my saw, although I am someone who, in our team brief, will plan exactly what we do in those circumstances and be ready to go on bypass with an auxiliary cannulation and so on. So, that's all part of our marginal gains factors and trying to get that patient through complex surgery safely. In addition to the procedural skills that you have to deliver, spinal drains for frozen elephant trunks, multiple arterial lines, PA catheters, vas caths, the complex monitoring that we have to do, and all to try and do that timely so we can get a knife to skin well before 10 a.m. is really tricky. So working with a set number of consultant anaesthetists for these cases, I think is essential from my point of view and for the patient's point of view. So to conclude, teamwork and this concept of teaming, which we do all the time, is essential. But the only core strategy that we have in that team is actually the surgeon anaesthetist relationship. Marginal gains within the team is essential and potentially very powerful over time, as we've described. And ultimately, this is for the patient. I think the value of anesthesia and the wider team having multi-subspecialty interests and that wide array of skills in cardiac, airway, ICU, ECMO, aortic, thoraco, etc., is invaluable if we are going to be able to get these percentages down to what the public or what the society or NACSA think we should be delivering at. And although as a surgeon, I'm very task focused in the actual operating bit, it does rely on teamwork, but the spotlight of that patient's journey and outcome, as I've tried to sort of highlight today, ultimately falls on that surgeon who has those results published. But of course, as I say, this is all about being able to deliver this as a team. And that is it, Paul.
Thanks very much, Ben. Appreciate your time, and I apologise for the title of the topic. Um, they're not meant to be causing con well, they are meant to cause controversy in some ways, but not
Yeah.
problems. Christos had a question in the chat. He's on a train, so he can't unmute. Is there any data from literature that you're aware of that show better outcomes when a surgeon works consistently with the same anaesthetist? I think I remember a while ago saying there was some data that showed that the anesthetic input was pretty insignificant to mortality and so on, but I don't know if you're aware of anything.
Yeah, I think there's actually, yeah, it's very difficult to study it, isn't there? How exactly could you study it without bias? So I think it's all mostly anecdotal, um, or says it's not important, as the rationale for why it's not so rigid. There is fluidity in this job planning, isn't there? That I don't always work with the same. I have a general cohort of a consultant anaesthetist that I work with, but it's not absolute and it can vary. So that's the give in the system. But if I was booking a redo arch and root, I would want one of the anaesthetists I work with consistently. I think that's a fair comment. But there probably is no actual outcome data to suggest it or to reinforce it.
So just quickly before I come to Damien's question, that was one of the issues that I wrote down is there enough expertise within the wider cohort to ensure that complex surgery booking doesn't have a negative outcome on the patient for waiting too long because they're waiting for your right anaesthetist to be there on the day. I suppose that's the advantage of having a group of anaesthetists rather than one specific one,
Yeah,
who can step into those cases. But do you ever find patients' disease has progressed because you've not been comfortable in booking a case?
I would say no, because I think the team at Barts is sufficiently large enough that we can work around things well. Sorry, my cat now wants to get in on the picture. Um, yeah, so I think it's all about plan job or team job planning, isn't it? So for the as much as the surgeons do that, the anaesthetist will also do that and project how many anaesthetists who are able to run complex aortic cases will be factored into that. So, it might not be my usual anaesthetist, but it would be one of Profu's anaesthetists, for example, who can cover it. So I think we're covered. I wouldn't say that a disease has progressed because I haven't been satisfied. I can't do it with my usual anaesthetist, I think. Yeah.
Damien, did you want to come in?
Yeah, thanks, Paul. And thanks for your talk, Ben. I really enjoyed it. And I think that, yeah, I totally agree. It's very important to have that consistent relationship between surgeon and anaesthetist. And I do my arch cases with only certain anaesthetists in Brighton. But I was just wondering how much in the preoperative process do you get the anaesthetists sort of involved? I mean, will they just see them when they're admitted for the surgery, or are they involved in the pre-assessment as well? Do they routinely? Would your anaesthetist routinely see the patient ahead of time?
It's a good question. For my patients, I don't request a specific anesthetic review, but I think they may automatically get a high risk sort of anesthetic review if they are deemed necessary. So some of my colleagues, like Professor U, as you know, would have that already plumbed into his pre-op strategy. Whereas I think mine would be directed if needed. Um,
It
because
seems
I
to
think the
happen.
system has to be robust enough to be able to do it when needed rather than just always.
It seems to happen for the Thoracos, doesn't it? Where there's a kind of a
Yeah,
team WhatsApp group, and the same
yeah,
at St Thomas's, where we get, as an anaesthetist, we get CC'd into the emails when a patient gets seen in clinic, um, and
yeah,
booked for surgery.
yeah.
Um, One question I had, which I mean, maybe Damien, you can comment on as well, is how does this reflect into the on-call situation where you might be doing some work which is equally complex, a full arch and FET for a acute dissection. But obviously you don't have the same ability to kind of pick your team, and have people who do these cases regularly. You might, I know at Barts, for example, the new locums will often go onto the theatre rota, and you've then got over a weekend potentially somebody who's having to be there for 72 hours to do the most complex operations, who isn't naturally in that elective team that's had years potentially of experience to build up. Is there any adjustments that you make as surgeons to that situation?
Oh, it's a really good question. And that is the reality of on calls at night. Is there are a lot of more junior consultant anaesthetists who are locums. I think, in my experience, they are very capable of doing those cases and getting the patient anaesthetized and induced safely, and therefore enabling us to go on bypass safely. And then there is a little bit of unknown as to what we're going to do. We know so much from the scan, but until we take the clamp off during circ arrest, and Damien will advocate this as well. But you're not absolutely sure what you might find. Like there could be a tear into the arch, and you've got no choice but to replace the arch in some way, and therefore there's no choice. You just have to do it. How the patient is managed coming off bypass, therefore, is the only other thing that can be controlled by the anaesthetist, and by which point probably help can be called upon. So I guess it's sort of somewhat yes and no to those things, those individuals then build up quite a lot of experience by managing type A's dissection and Barts. We do a lot, so they get a rapid learning curve and ability to manage those cases.
Sam, then from Birmingham.
Yeah, sorry, can I just come in on that, Paul?
Yeah, of course.
That point.
Oh, sorry,
I think as Ben said, you just got to make the best with that situation that you have, don't you? I mean, we don't even have a national mandate that all aortic dissections need to be operated on by aortic surgeons yet. So in getting to the point where we have a consistent team is pretty much, that's quite a long way down the road to have a separate anesthetic rota, let alone not even a separate surgical rota yet. So I think we just do the best we can, and that's, there's many factors as to why emergency mortality is higher than elective mortality, and it's not just because the patients are sicker, although it is mostly because the patients are sicker, but it's a combination of all those little factors that are not quite as optimal as they are when you're doing it in the light of day with your normal team. So yeah, it'd be nice, but I think you just got to make do with the best that you have in that situation, don't you?
Thanks, Damien. Sam, did you want to come in?
Yeah,
with
I
your
just
question?
wanted to come in on some of the points about on call and things. I mean, where I work, we do a lot of sort of super niche stuff, like some of the aortic stuff, ACHD and things. And the way we've kind of developed it is you'll probably have like a core of 2 or 3 people that are particularly do each thing, and then often these cases often will benefit from 2 consultants if you can arrange it. And so whatever list it lands on, one of that group will try and then go and be the second person, and that way you get the best of both worlds, that the rest of the group then know what to do at 3 in the morning because they've sort of done some in the day, and also you get sort of 2 heads better than one, and potentially some training for succession planning as well. But it's quite hard to convince the managers.
Yeah, that's what we've had trouble with, is getting 2 consultants on some of our most complex cases is a real struggle sometimes.
Hopefully AXA will help with that.
Yeah. There was a comment raised by Tom in the chat just to say that a good parallel is that of vascular anesthesia, which I think relatively widely across the board certainly is the case at St Thomas's, is that there's a very small group that will be doing the open major vascular cases, but however the entire cohort of general anaesthetic consultants will be expected to anaesthetize for a ruptured AAA out of hours. and they often meet the same kind of governance issues about whether or not they should be doing some of their getting some exposure of elective vascular work to essentially maintain their skills in vascular anaesthetic cases. Julia had a quick technical question, which is, in practice, how often do you truly have to turn a dissection into a kind of complex aortic full arch and FET case? Which Ben, you might have some numbers of how many you do per year for acute dissections.
I want to say 20% off the top of my head, but I don't know the exact figure, but I think it could be in that region. I would say probably 20% needs some sort of complex thing, like if they've got an ischemic leg, we might have to do a fem-fem crossover. If they have some sort of strange arch tear that we definitely know of, then we'd have to do a frozen elephant trunk and so on. So I think about 20% in reality.
So it's a significant risk if you're with essentially what is we're all specialist anaesthetists, but what's a cardiac generalist as opposed to an aortovascular specialist.
But we'd never put a spinal drain in an acute dissection, for example. So that would be a rescue thing on ITU. So otherwise the anesthesia is the same. So it's
yeah, that's reasonable. Any final comments for Ben, just out of the interest of time? I'm aware that we're slightly overrunning already. If not, I'll say thank you very much for being willing to contribute to this meeting.
Thanks for inviting me. Thank you.
No worries.